Wonderful. Hello, everyone. Welcome to today's Q&A session all about HIE and genetics. I am Deanna Bryan. I'm the program manager at Hope for HIE, and I am joined today by two really esteemed experts in the field of genetics, neonatal care, and more. I have Dr. Christian Parobek and Dr. Stephen Lazar. We'll start with Dr. Christian Parobek. He's a renowned maternal-fetal medicine specialist at Baylor College of Medicine. His research focuses on the intersection of maternal health and neonatal outcomes, particularly regarding how genetic factors influence conditions like HIE. And joining him is Dr. Stephen Lazar, a pediatric neurologist, also affiliated with BCM. And he has been deeply engaged in research that explores the genetic underpinnings of neurological conditions like HIE. And his recent work that we're going to talk about today, particularly on the etiology of autism in relation to HIE, has been really groundbreaking for our community and has provided a lot of vital insights for our families navigating some of these complex diagnoses. So together, they bring a wealth of knowledge and experience that's really invaluable to our understanding of HIE and genetics. And they're going to share their insights with us today on the evolving landscape of this research in HIE, along with the challenges faced in this field and any implications there are for treatment, diagnosis, and long-term planning. So thank you again, both of you, for joining us. I know that I gave a brief introduction to you both, but perhaps you guys can expand on who you are, what you do, a little overview of your careers, and where in your work you developed an interest in HIE and the potential genetic impact or influence and where that came about. So maybe Dr. Lazar, maybe we can start with you.
Sure. Thank you so much for having us. It's really an honor to be able to speak with all of you. Again, so I'm Dr. Stephen Lazar. So I am, as was mentioned, a pediatric neurologist and neurodevelopmental disability specialist. So my background and interest kind of in this field is really kind of come full circle. So I am a first-generation college student from central Pennsylvania and had a little bit of exposure working with adults with disabilities, sometimes at summer camps and other things too. And when I went to college, I started to work with a group that focused on neuroimaging research and kind of just the broad spectrum of genetics and developmental disabilities. And from there, I was going to be an adult neurologist and work with adults with disabilities until actually my obstetrics rotation in medical school. And so I realized I wanted to follow the babies. And so from there, I decided on this combined training in pediatric neurology, general pediatrics, and developmental disabilities. So kind of integrated training. And I did all of my training at Baylor College of Medicine and Texas Children's Hospital, and I have since stayed on at faculty. And right now, my practice is I'm the medical director for our neonatal follow-up clinic. And my clinical practice, I consider it to be umbrella care. So I work within fetal neurology through neonatal in the NICU, and then also for long-term clinical follow-up.
Wonderful. Thank you. Dr. Parobek, your turn.
Yeah, thanks. Like Dr. Lazar said, thanks for having us. I'm really excited to be here. I know both of us are. And this is a topic that's really interesting to us and I think important for the HIE community as well. So I've been interested in genetics for a while now. I did grad school studying malaria genetics, but I realized in medical school that I loved obstetrics. Kind of similar to Dr. Lazar, I decided that I wanted to follow the fetus, so a little bit different there. But one of the great things about obstetrics is you get to care for two patients at once, the mom and the baby. And obstetricians send a lot of genetic tests. And so there's pretty big potential to find out things that are going to affect the pregnancy and affect health as neonates and kids and adults. And we can find that out before delivery. And sometimes knowing that information before delivery can be quite helpful. So I think that's why obstetrics is a really exciting place to be working in right now. As for HIE, I hadn't really heard of it or thought of it until I became an obstetrics resident. And then I realized how important it is, how important HIE is to families who are affected by it. And I realized that obstetricians spend a lot of effort trying to predict which fetuses that we're caring for are going to end up developing HIE. And the tools that we have to do that are really limited. And so quite honestly, we're not that good at predicting it at this point. And so once I reach fellowship, and I'm in fellowship right now at Baylor and at Texas Children's, I had the chance to explore the genetic associations with HIE a little bit more. And so I'm excited because I think what we've found and what others have been finding as well have the potential to make a difference for some families.
Absolutely. And that's why we're so grateful that you're here, is to kind of walk us through, give us an overview really of the understanding of genetics, and more importantly, like how that impacts our families, how it impacts diagnosis and treatment, and all of these things that are pertinent to them. So with that, I think that's a wonderful segue into kind of our first topic, which is all about understanding genetics and establishing the why behind all of these genetic underpinnings and understanding the significance of them. So if we could just begin by providing more of like a foundation of knowledge. We know that there are lots of different terms associated with this, especially when discussing HIE and genetics. There's things like genetic influence of parents, gene expression, genetic disorders. So if you, one or both of you, could break those down for us, that would be a great start.
I can start by talking about some of the tests that we commonly
Perfect.
send prenatally or postnatally as well. And then maybe Dr. Lazar can talk more about how those can be specifically applied in the NICU, for example. So when I'm talking to families about genetics and about different genetic tests, I like to think about the genome, the human genome, like a library. And in this library, you walk in and there are shelves filled with books. And in this library, there's about 20,000 different books corresponding with 20,000 different genes that make up our genome. And then the different shelves you can think about kind of like the chromosomes. That's how structurally these genes are arranged in relation to each other. And so the tests that we have a few different tests to try to assess, is this library complete? Do we have all the books here? And are the books intact? Are they spelled correctly? So one test that I think a lot of families encounter in the NICU or even out of the NICU is called a chromosomal microarray. And that's a test that's probably 20 or 30 years old clinically. And it's a useful test because it essentially scans through all of the shelves and says, are there any duplicated or missing shelves here? Are there any big blocks of books that just aren't there, or any blocks of books where there's extra copies? Another term that families will hear about is called an exome. So the exome is where you go through and you open up every one of those books in the library and you read it in detail and you look for spelling changes that could make a difference in the meaning of that book or the difference in the meaning of that gene and the way that it functions. And then a genome is a test which is helpful because it combines both of these functions into a single test. And genomes are a newer test, and traditionally they've been quite expensive because it requires so much sequencing power to get useful clinical data out of a genome. But as the cost of sequencing falls, we're able to deploy this more rapidly in the NICU and try to get answers for families sometimes as quick as within a week after we send tests.
Yeah. And so, and that's a perfect summary, because I think that one of the key things that a lot of families are not always explained is that I hear often in my clinics, oh, they did the genetic test and they said everything was fine. And my next question, which you'll hear a theme of me today, is, well, but why? And also, but which genetic tests? Because not all of them are equivalent. And sometimes even these more general, broad spectrum tests pick up things that these more expensive, fine detail tests could miss. So for example, if only some of your body's cells have these changes, but not all of them, some of the tests can pick that up, but others might miss it, even in the full detail. So I think a lot of times families think of prenatal testing, and that's kind of their non-invasive parental testing, so that NIPT. And that only really accounts for a handful of thousands upon thousands of different genetics that can lead to challenges and symptoms. And so just for that screening, it looks for a couple big things, but it doesn't look for all of them.
Right.
And so there's different levels in which we can look at the genetic testing. And I think that from that, that's really exactly what Dr. Parobek mentioned, was that this really only tells us, is the spelling right? And is the instruction manual clear? But it doesn't tell us if the body's following the instruction manual. So that's kind of where this idea of gene expression is. So your body can change how much they turn on certain DNA and turn it off in different states. So if you're sick or fighting off an illness, it turns on certain genes and genetics to help your body's immune system ramp up. And that can happen also if you encounter an injury. So kind of if there's a low oxygen or hypoxic ischemic injury, different genes can then be expressed, underexpressed appropriately to allow your body to manage and work its way through an injury. So that's really one of the new emerging areas, or how the genetics express differently. But I think a lot of what we're working on right now is kind of that very big underlying, where's the instruction from the beginning? And we know that most of these changes in instructions happen at or before conception. So one of the big things we think about genetics is I always say, well, nobody in our family has anything, so how can it be genetic? And it's very important to know too that you can have inheritance, meaning half your DNA from mom, half from dad, and they combine and integrate. And when they combine and integrate, new changes can happen. And so that's sometimes you'll come across the words de novo or new. So just because there aren't things that run in families doesn't mean there couldn't be genetic changes or influence just within somebody who's affected with certain symptoms.
Absolutely. And I think this is, and you can answer this too, but this is part of why this is so significant, right? And that's kind of the next question. So what's the why behind genetic investigation, and why is it such an important emerging thing why does it matter? Dr. Lazar, you can start, I guess, if you want to expand on that.
So I think that the question that runs through my mind anytime I'm in the NICU, in doing a consultation, even before birth and things too, is like, well, why do they have this finding? Why did this occur? Why did this happen? And when we think about genetics, so I want to take kind of a bigger step back. It will tie into, I think, some of our later questions. So as a developmental specialist, I really conceptualize and think about different levels of diagnosis. So anybody that comes to see me has a collection of either specific symptoms or specific impairments. So it could be, I don't move my legs as well as they should. I have seizures. I had an abnormal brain MRI. All of those are very specific kind of clinical symptoms. And then we gather and take those symptoms and put them together to understand what we call a categorical diagnosis. So how do we put these things together to make a diagnosis based on who's in front of us and what information we have? Now, to use HIE for an example, we know that there is neonatal encephalopathy, which is kind of this broad term of a baby after being born isn't quite doing the reflexes we expect, isn't quite moving as expecting, breathing as much. And it just seems to be there's something else going on where we need some extra support. Now, one of the reasons for why that can happen could be hypoxic ischemic encephalopathy, meaning that there was a low oxygen or lack of blood flow or low blood pressures or any number of factors that then lead to hypoxic ischemic or low oxygen injury to the nervous system. And that's kind of putting together, you have a clinical neonatal encephalopathy with that history of cause that's low oxygen. So there are different levels. And then we look into what we call the etiologic diagnosis, and meaning the why. Why did this happen to begin with? And the developing brain can have so many different things that interfere with it other than expected. You could have low oxygen injury, toxic exposure, Or even if you think of older kids, like traumatic brain injury, so from motor vehicle collision or things like that, that can all interfere with the way a typical brain was expected to develop. And a couple major parts of that also include the genetics, because that instruction manual helps tie into the pathways and the connections between parts of the brain. And so when I do a clinical diagnosis of HIE, my next question is, well, why did they have HIE? Because HIE isn't the only etiology or cause of or why this happened.
Mm-hmm.
And so genetics can help us understand, one, just to know not necessarily, there's a little bit of emerging mark of risk of further injury or things happening in the future if there's like metabolic, meaning the way your body processes energy, and could have specific interventions to help prevent things like that in the future, or understanding all of those consequences of a low oxygen injury. And that could be like later seizures and development of things like that, because we know, and I know I'm taking a little bit too much time from Dr. Parobek, but to branch off that, we also know that we do and recommend for the right person that full body cooling or lowering the body temperature down to help preserve and protect further injury. Now, just because somebody had HIE doesn't mean that there aren't other factors that caused them to have HIE that could implicate the future. So there's a number of new genetic findings that people who present clinically as having neonatal encephalopathy or also put them at risk for having hypoxic ischemic encephalopathy. So it's in a way both, but the implications for how long do we need to stay on seizure medicines for? Is this really what we'd call epilepsy, or is it just provoked seizure, meaning the seizure was caused by the brain being irritated from just the injury? Or is it a combination of both? So that's some of the reasons why myself, that anytime I see somebody who comes in my clinic, they said, oh, they told me I had a birth injury or I had an HIE, or I kind of really try to dive down to understand the big picture why. And even in the classic scenarios of things like placental abruption, meaning the placenta comes off the wall of the uterus, or even some of these factors are like, well, they just thought it was a difficult labor. I want to know why. And sometimes we never get that answer, but genetics are really helping us.
Wonderful. Dr. Parobek, anything to add?
Yeah, no, I think that was a great summary. And from an OB perspective, when we think about risk factors for HIE or why HIE might happen, we think of we know some of the risk factors for it. So things that Dr. Lazar already talked about, but preterm birth is a risk factor, fetal growth restriction, placental problems or placental insufficiency, extreme oxygen deprivation during labor. All of these are associated with HIE, but as OBs, we try to minimize and reduce the risk and the effect of problems like this, but we're limited in our ability to predict which babies are actually going to go on to develop HIE. So I think all OBs have had the experience of delivering a baby with none of these risk factors who unexpectedly goes on to develop HIE. And on the flip side, every day we deliver other babies with one or more of these risk factors that don't develop HIE. I was on call yesterday and delivered a number of babies who had various of these risk factors. So far, knock on wood, they're doing well. And so it kind of begs the question, why do some babies end up going down the HIE pathogenesis pathway and others don't? And the main tool that we have for predicting how a baby might do during labor is fetal monitoring. And so fetal monitoring was originally introduced during the 1970s and 1980s, and it was designed as a way to predict and prevent stillbirth during labor. And it was incredibly effective at doing that. Surprise stillbirth during labor very rarely happens anymore. But in the decades since it was introduced, it's experienced some mission creep. And now we as a field try to apply this to prevent cerebral palsy and to prevent HIE. And as a result, partly as a result of this, the C-section rate has increased about sixfold from the 1970s. It was 5% in the 1970s, and it's about 30% now. Despite that, the rates of CP and rates of HIE overall are unchanged since the 1970s. And so again, it makes us wonder, why are we doing more C-sections? We're shortcutting and short-circuiting the hypoxic stress of labor, but we're not really preventing the outcomes that we want to prevent.
Right.
So
Right.
that's where genetics might play a role, and we think it does.
Yes. And this is another good segue to talk about HIE genetics across the lifespan, truly. What have you both seen in your training, research, or practice that has changed over the last decade with understanding multiple etiologies of HIE from both of your specialties? Dr. Parobek, maybe we can begin with you from MFM standpoint, and then Dr. Lazar, if you could then follow up with your insights from a pediatric neurology standpoint.
Yeah, I think I have less to talk about here than Dr. Lazar does. Because from an OB side, not much has changed since I started training, and within the last decade as well. Some OBs may be starting to have a realization, or at least have the thought that there may be genetic contributors to the pathogenesis of HIE. But at this point, prenatally and intrapartum, we're not managing pregnancies any differently than we did 10 years ago or 20 years ago. So I think if there's going to be change that's going to happen with obstetricians and with the prenatal space, that's in the future, but it may come. Postnatally, though, I think there's more happening.
Yep. And yeah, so I would agree. I would say that it is every 5 years, I would say that I give any type of talk or work through kind of introducing genetic testing or talking about all of these things. It's a completely different talk. So, I mean, we're in a completely new world. It's only been 25-ish years ago that we've actually sequenced the human genome. And now we're doing direct genetic testing that scans every single letter of DNA for under $1,000 or $2,000. And that's typically kind of how the prices come down so much that where now insurers are covering it for the most part, and they're able to get readily actionable testing. And they're also understanding that sometimes just having a why or a genetic answer underlying it, even if it doesn't have a treatment that fixes the underlying piece or changes the underlying kind of outcome at the end of the day, having a why answer sometimes is enough to be meaningful and understanding, because there's always so much guilt, especially when something happens that we weren't expecting from everybody, especially the parents. Yes. And genetics can it can help quite a bit if we get an answer. And I often say too, even if we don't get a genetic answer for why, there's likely a bunch of very tiny small changes that all contribute. And our tests only pick up those big volume changes, not necessarily size, but big impactful changes, not all the small thousands of little changes that put you at risk. And I do think that we are really moving from what used to be called a phenotype first approach to genetic testing, meaning that we have a specific set of symptoms, we know what this condition is, we're going to test for that, to what we call a genotype, meaning we start with the broad genetic that screens everything, and then we see, does that fit the clinical feature? Because there's so much we're learning every single month, year. There's more and more genetic variabilities that are being associated with all different types of conditions. So, and that also ties into that it's not just one and done genetic testing. A lot of these higher level exome sequencing and genome sequencing, we repeat the analysis on the data that's already been collected. And people had these tests 5-10 years ago. We reanalyze the data and we now get an answer because it's only been within the past 10 years that's been reported. Yeah. So we're in an evolving and new world. And I would say that it's really that the biggest change postnatally is that we are being much more upfront about offering and recommending genetic testing, especially if something just doesn't quite fit.
Absolutely. And are there certain genetic conditions that commonly occur alongside HIE, and how might those co-occurring conditions influence potential long-term outcomes. Now, Dr. Lazar, I'm going to speak to you because if you could specifically touch on this question and refer to your own work of the etiology of autism, because especially regarding how HIE contributes as a clear identifiable cause, and how by recognizing HIE as an etiology, this can really highlight potential pathways and expectations for cognitive, social, behavioral outcomes over time, and then create room for targeted support. That would be, if you could kind of give an insight to our community about that work, that'd be amazing.
Yeah, and thank you for that question too. And I think it ties into a little bit when I talked about this level of diagnosis. So the way in which we conceptualize this is that we know that there are many etiology or influencing factors that can affect the developing brain and nervous system. And that's that genetic, hypoxic ischemic, toxologic, kind of all of these things, then also just typical developmental variation, because we know not everybody is exactly one piece. And all of that can play into this more general concept that some have been calling kind of developmental brain dysfunction, developmental brain interference, and this kind of more generic term that all of these can impact the brain's wiring and new connections and maturation. And that's kind of a black box that then leads to a wide variety of those symptoms, because not everyone with the same genetic condition or even the same exact spelling change has the same exact symptoms. They're not one-to-one, because there's all these other factors that influence how something can be affected. So could there be genetic risk that puts you at risk for having HIE? And then those together in a unique person lead to this set of symptoms. And they're not one-to-one. And so that's really where we know that all of the different specific impairments people have, social difficulties, communication difficulties, motor difficulties, they're clinical diagnoses. So when I talk about etiology of autism or etiology of intellectual disability, cerebral palsy, all those things, those diagnoses don't change based on whether or not you have a genetic cause. And because what you have is a diagnosis that was built based on clinical judgment. So meaning based on the symptoms in the person you have in front of you, not necessarily the why. It's a different level of diagnosis. So I say they have autism due to presumed genetic cause, or autism due to presumed HIE and genetic cause. And then there could be some of that crossover. So that's why we know that I think one of the recent changes is that people were thinking about genetic testing if they also had after HIE. Years later, if they had autism, if they had more developmental impairment than expected based on the story or the brain pictures. And so they were thinking back, say, well, what else? Now we're starting there and thinking that unless it was very clear and obvious that this medical emergency happened that led to it, then we're thinking genetic first while we're still doing all those supportive protective brain health. So I consider it that, I think one of the good questions was a lot of families do like, oh, they have autistic traits.
Right.
Or they might have these symptoms, but because of this, we're not going to call it autism. That's in my mind completely wrong. But as long as you meet the clinically defined criteria for autism, you have a diagnosis of autism, regardless of why you have those symptoms.
Absolutely. Thank you. Dr. Parobek, did you have anything you wanted to add to that question? I didn't mean to exclude you at first.
No, that was great. I always learn a lot when I talk with or work with Dr. Lazar. So I love this.
Perfect.
I mean, just to the point about what specific conditions may associate with HIE, at this point in time, the data there's not been a lot of data collation that's really happened. So we don't have a great list of conditions at this point, but there have been a handful of conditions that have come up over and over in the very few different studies that have been performed so far on this. And it seems like these conditions fall into a few different categories. Some conditions may mimic HIE. And so maybe there's a genetic cause for seizures or a genetic cause for encephalopathy. And that can create a phenotype, that can create a set of a clinical picture that looks like HIE. And, with the right labor story or with the right prenatal story, that can lead to a diagnosis of HIE. There can also be conditions that could make HIE more likely, kind of like Dr. Lazar was talking about. So conditions that might affect placental function over the long term of pregnancy, or might affect, fetal circulation and the ability to perfuse fetal tissues before or during labor. There can be disorders of energy metabolism, and there's been a few of these that have come up multiple times. And then disorders of redox homeostasis as well could impair the body and tissue's ability to deal with hypoxic conditions and to clear out kind of the toxic waste products that are produced during hypoxia when tissues don't have enough oxygen. And so these seem to be some of the themes that are coming up over and over.
Yep.
Yes.
And I would just also add too, I think that this is something that's an interest of mine, just kind of clinically too, is that right now, a lot of times known complex genetic disorders. So if they say, oh, it's a complex chromosomal or kind of these things too, a lot of that times that's an exclusion criteria for total body cooling. In the right clinical setting, even for HIE. So I think that there's still more to be learned. And I think that there's a theoretical risk that if there's already this known underlying genetic reason for why you may have diminished breathing ability, diminished ability to transition into life, and could actually the cooling do harm? I think that's the theory for why it's not offered. And I think that that's likely to change in the future too, because HIE is not only for the person who had the quote unquote low oxygen birth injury very clearly. There's genetics can interplay from just like Dr. Parobek mentioned, from the placental growth, because it takes three. It takes mom, fetus, and the placental interactions that allow this blood flow for growth throughout pregnancy. That could be affected. It could be genetic differences that lead to, around the time of birth, not dealing with transitioning into life and stopping breathing, that then leads to an acquired injury of HIE. So or it could be that you have the hypoxic injury or the low oxygen injury, and your genetic makeup underneath makes you not tolerate it well. That'll lead to more severe effects. So I think that that's kind of how it can interplay with all these different pieces, because it's not genetics or HIE. It's very mixed.
And there's this, I love the way you described that, because there's this concept of Everest in utero. This was an idea that was introduced 70 years ago by some obstetricians at the time. And the idea is that fetuses, babies, as they're developing in utero, they have limited oxygen exposure. If you think about it, it's incredible that they have any oxygen in there, right? The oxygen has to get outside, down the windpipe, to the lungs, into the blood, across the placenta, and then into the baby. So it's amazing that they have any oxygen. But the idea was introduced years ago, and since studies have actually backed this up and found that this is more or less true, that a fetus in utero has similar oxygen levels in their blood as an adult at the top of Mount Everest with limited oxygen.
Wow.
And that hypoxia gets even worse during labor. And so fetuses are built to deal with that, and that's okay. Most babies, as they go through labor, they can go through hypoxia and they deal with that stress, okay. But like Dr. Lazar was saying, if they have a defect of something like an energy metabolism defect, where one of their ways that the body has of making energy doesn't work well, and in that hypoxic situation where they're exposed and transitioning, as he said, they don't have that tool in their tool chest to keep supplying glucose to their brain and to other body tissues. And so that may predispose for an injury to occur.
Yes. And as we all know, a lot of these genetic insights, they may influence care. And that's a lot of families in our community really, really care about. So if you could provide some insight, Dr. Parobek, maybe you want to begin if you have something you'd like to say in terms of how might these genetic insights influence the care and treatment options for affected mothers. And then we can go on to babies and children.
Yeah, I think there's a couple ways in which this could affect care before delivery. And I think one of them is knowing about a condition beforehand could help families with IVF, for example. I came across a boy who was delivered at our institution and was diagnosed, had encephalopathy and was diagnosed with a genetic encephalopathy. There was really no concern for HIE for him. But digging into his chart, he had an older brother that was born 2 years prior in another state. And this older brother was diagnosed with HIE and unfortunately died. And at the time, there wasn't any concern that this HIE was genetic or related to genetics. They had a reasonable explanation for what they thought was going on. And so no genetic tests were sent for that older brother. My suspicion is, I don't know this for sure, but my suspicion is that both brothers had the same condition. And it was really just recognized with the second brother and wasn't recognized in the first brother in the same way. And that could have been prevented, or at least potentially, the severity could have been lessened. So IVF would be an option, having a lower threshold to let that kid go through a stressful labor process may or may not make a difference. We don't know, but it's something that could be considered. And that's something when I talk to obstetricians about this, OBs' minds often go there. They say, if we know that a kid may not have all the tools in their tool chest to be able to deal with stressful labor, does that mean we shouldn't be putting a kid with potentially a genetic defect of energy metabolism, for example? Should we not be putting them through the stress of labor? OBs, as a profession, we are trying really hard to reduce the C-section rate and not do so many C-sections. But at the same time, our primary goal is healthy baby and healthy mom. So trying to balance those two things against each other, that's kind of where our mind goes. So those are a couple ways where knowing about genetics and the genetics relationship to HIE might make a difference prenatally. But I think postnatally can also make differences as well. But Dr. Lazar can talk about that better than I can.
Yeah. I would say that this is something that I think that as we're getting more and more advanced, the availability and recognition and earlier genetic diagnostics is going to come early and earlier. So right now, as part of some of my fetal consultations, through amniocentesis, we're able to run exome sequencing directly on the cells to be able to do this really advanced testing even before a child's born, to really even be able to help prepare and guide and understand what the relative risk is. So if we think about things that either one could lead to an acquired injury of HIE or mimic kind of a neonatal encephalopathy or something in the middle, we can be prepared for and know it, especially, they immediately need to have an IV placed and high levels of glucose given. To keep their sugars up, or kind of, hey, there's an extremely high chance, so we need to have a neonatology team present to be able to intubate and provide that breathing immediately, and knowing that they may just need to have an intubation as opposed to a little resuscitation, because this all started before the baby was born. Right. And there's also this concept that some of the HIE starts prior to delivery. It's not just kind of right after delivery. And I think that's a little bit of that prenatal in my perspective. But then once they're kind of out and we start seeing them, see how things go, the number one thing is just kind of, especially whether or not they have seizures and also their muscle tone. So I liken this too. So one of my interests in work is with early detection of motor disability and cerebral palsy and these things too. And it's now kind of becoming just like autism and intellectual disability, that the first line understanding of why is genetics. And there's a lot of genetic impact and why. And so there's actually some really good information that do something. And I think Dr. Parobek may mention this a little bit later, that one of the major areas of research now are what we call etiology agnostic testing. So meaning that we take anybody that has something diagnosed in their chart and blanket do genetic testing, and we're finding all of these new associations. And that impacts my treatment too, because if they have a specific genetic change that leads to HIE or can look like HIE and seizures, I may have specific anti-seizure medicines that I need to avoid because it could worsen things, or specific medicines to give that can just help. So one of the examples is a pyridoxine-dependent epilepsy. So it's a B vitamin that the body's deficient in creating and metabolizing, and they can have very, very bad encephalopathy when they're born, a very kind of poor prognostic EEG, and kind of all these terms. And if they just get a huge, large dose of B vitamin, they can normalize their brain waves. And so having earlier access to this testing and diagnostic can help us understand all of this interplay and actually affect our treatment pretty commonly.
Yeah. And what would you say is changing in the current care of babies with HIE regarding genetics? Like, for example, we've seen an increase in the use of genetic tests to kind of rule out specific genetic disorders that may mimic, or as you said, maybe exacerbate HIE, allowing for a more accurate diagnosis and tailored care plan, as you said.
Yeah, and I think Dr. Parobek and I have been talking a lot about this, and that's how we kind of came together, was that I am clinically of the mind, I need a really, really good excuse to not recommend genetic testing in anybody that has an HIE picture. So I would say that often right now, most places are, well, something just doesn't fit, or they're more seizures than expected, they're lasting longer, or the MRI was normal after the cooling, and there's a whole lot coming out. And I know, talking with Betsy as well too, kind of this idea of image negative HIE and some of these things too, and the implications, and trying to understand this balance. I personally think we're moving towards most, if not all, outside of specific instances, should start getting genetic testing.
Yes. Dr. Parobek, is there anything you'd want to add, or we feel good?
We covered it.
I had a feeling. I concur. So as we know, there's always, there are challenges, there are barriers or ethical concerns, you name it, associated with finding these genetic insights. So if you could kind of outline some of those for us, that would be great. Potentially, I know maybe to include in your answer, the complexities associated with clinical exome sequencing, whether as a standard diagnostic tool, and what can come with that. Dr. Lazar, you're nodding your head, so we can begin with you if you'd like.
So I think that there's so much that goes into genetic testing. There's risks that are associated with genetic testing. And I think that depending on who you talk to, there's the list of things that need to be covered before a family can truly consent or agree to genetic testing is quite long. I would say that there's definitely a balance in for how comfortable the individuals offering genetic testing are. I would say that in general, I say that there's 3 possible results. You can have a pathogenic or a causative finding, meaning there's a change. We know this is related to everything we've seen, and that gives us our answer. And you can have a negative or completely normal test. And that doesn't necessarily mean there aren't genetic factors. It just means there isn't one known that we picked up on this specific test. And a big risk that I consider a risk is this, what's called a variant of undetermined significance, meaning that, hey, there's a change here, and we're not exactly 100% sure what it means. And that can lead to more testing, more pokes, more type of things, and sometimes even more gray area and unknown. And that in of itself is a risk. And outside of that, we also know that because we're doing broad testing, there are things that we call incidental findings, meaning findings that we weren't expecting. I use, for example, the BRCA gene, or the BRCA gene, which is the breast cancer associated gene. I've actually worked with a family who I incidentally found that the child and the mother, because we test both parents if possible, and the child, because we're focusing on the child and using the parents' information to understand it, not necessarily test the parents themselves. And it depends on the lab whether or not they'd report these incidental findings in parents if the child doesn't have it. But we found an incidental clear change in this gene that then actually impacted mom, and she actually found pre-symptomatic breast cancer and actually underwent treatment that would have been very severe if it was missed even for another year. just given because of that genetic difference. So that's one extreme example, but that's the type of incidental or unexpected findings. And her breast cancer had nothing to do with the child's intellectual disability at that point.
Right.
And Dr. Parobek, I think you might have some more kind of on the counseling side.
Yeah, the counseling, we kind of cover the same things prenatally and postnatally, if we're able to get prenatal testing approved and paid for. I think other things that we want families to know beyond incidental findings is that sometimes those incidental findings can have an effect on the patient's eligibility for insurance. So there's a federal law called GINA, the Genetic Information Non-Discrimination Act, and that protects all of us from discrimination by our health insurer on the basis of our genetic testing. So that family that Dr. Lazar was talking about, that family shouldn't have experienced any changes in their genetic, in their health insurance coverage because of that test.
Right.
But that if that mom didn't have life and disability insurance locked in for herself or for her kid, potentially, if she were to go out to and apply for that, life or disability insurers could ask her, have you ever had any genetic testing? And what were the results of that? And that may affect their willingness to cover, to insure a family or to insure an individual. So that's something the family should know about, kind of go into that with their eyes open when they're opting for incidental findings. It's also kind of like Dr. Lazar mentioned, it's an imperfect test. So sometimes he mentioned there can be cases where we come back with a negative answer. We say at this point in time, we didn't find anything that explains what's going on for you, for your kid, for your family. But at this point in time, there's 20,000 genes in the genome, and we only know the function of about 5,000 to 7,000 of those. So there's more that we don't know than we do know. And that's why, like he mentioned earlier, reanalysis in 2 years or 3 years, or when some new feature develops, can be helpful and can actually turn up findings that we weren't able to know before. So it's not always a silver bullet or a panacea. It's sometimes a process to come to a genetic diagnosis, if there is a genetic diagnosis. Yeah. And then I think the other concern is access. Dr. Lazar mentioned how cost has come down so much, and it has. 25 years ago, that first genome that he talked about, I think that cost over $1 billion. And now you can get a genome for $1,000 or less in some cases, which is still a lot of money when you're doing 3 of them, when you're testing baby and mom and dad, but it's less than a day in the NICU costs, that's for sure. So that's something that fortunately at our hospital, they've prioritized the availability of genetic testing for kids that are admitted. And we're really fortunate to work in a setting where that's available to us and where we can send those tests without having to think about how that cost is going to have to affect the family, or whether or not the insurance is going to cover that. But there's a lot of NICUs, there's a lot of hospitals in the country where either they just don't have enough providers who are comfortable sitting those tests, or they've seen that it might make an effect on their bottom line, and they say at this point we can't afford to send these tests for families and patients. And so that's another big access issue, is that the availability of this testing probably does at this point in time depend on where you deliver and where your baby is being cared for at. So hopefully that'll get better in time, but it's a problem now.
Yeah. And it's the problem that we're not unfamiliar with too, for so many reasons, especially, availability of therapeutic hypothermia. I mean, this is a recurring pattern that we do see in our community a lot. In terms of research, Dr. Parobek, do you mind sharing with us the research you're working on, some of the hypothesis generation you have about HIE and genetic influence over some causation?
Yeah, so I was really fortunate when I started fellowship here to have the chance to work with some folks in the genetics department to explore and analyze the genomes of a cohort of kids who had received a diagnosis of HIE, and many of them had undergone cooling for HIE as well. And out of the 24 children that we actually had access to that had had HIE and had undergone genome sequencing or exome sequencing, 6 of them had diagnostic findings that typically explained what was happening with them. So 25% genetic diagnosis rate. Another 6 had suggestive findings that were interesting and perhaps related, although they weren't diagnostic at this point in time. And we also looked in detail to see whether or not there were any prenatal or labor risk factors that associated with the probability of actually receiving a genetic diagnosis or not receiving a genetic diagnosis. Our hypothesis was that unexplained HIE, HIE where the cord gases were totally normal, where there hadn't been any sentinel labor events like an abruption or a cord prolapse or a uterine rupture. We thought that genetic diagnoses would be more likely in unexplained HIE. But we found genetic diagnoses in both, unexplained and explainable HIE, which was really interesting to us. And that's been, we wondered about those results, but that was recently confirmed with another study that came out of China. There was a study where the investigators in China performed exome sequencing in about 1,500 kids who had cerebral palsy. And there's many CP sequencing studies, but the thing that was unique about this one is that they subdivided their groups into groups who had experienced a clear hypoxic event during labor and those who hadn't. And the genetic diagnosis rate was actually higher in the cohort that experienced a hypoxic event during labor than those that didn't, which was, again, a surprise, but may actually make sense in context of all that we've been talking about. So some of the genes that we have found and that Chinese group found and that another Canadian group found that published their results last year, they fall into these categories that we've been talking about. So there's some conditions that seem to mimic HIE. There's some conditions that are problems with energy metabolism. There's some conditions that affect things like placental development or function. And so at this point, we're just trying to broaden this work and test some of these hypotheses a little bit more carefully. Dr. Lazar and I are working on a more detailed retrospective analysis. We are starting up systematic reviews of the existing literature here. And, I'm trying to get a study off the ground where we're going to do prospective recruitment and sequencing of hopefully all families in our NICU who are undergoing cooling for HIE. And then long-term, I'm interested in pursuing animal models of this as well and exploring genetics and the association with genetics in an animal model and then exposing that animal model to hypoxic conditions that are common, that are normal during labor, and seeing what the outcomes are there.
Yeah, well, we're so excited for you to kind of see this through, and we can't wait to learn more about it. I know that you mentioned, work that you're doing with Dr. Lazar as well. Is there anything else that you know of what's next in research about any upcoming studies, maybe ones you haven't mentioned before, that you're excited about that could explore genetic factors of HIE, or is that what you were referring to before?
Yeah, Dr. Lazar may have other leads and may know more than I do as well. But, I think that part of the future, which he alluded to, is really trying to drill down and see, which kids with HIE need genetic testing. Can we determine that from the outset? And the way to do this, the only way to do this is to actually just give genetic testing, perform studies where we do genetic testing for all the kids with HIE in a unit. And see what the outcomes are. Do all kids need sequencing, even if their HIE is attributable to a car crash and an abruption and kind of an emergent delivery because of that, or are there subsets maybe like that won't benefit from sequencing? We don't know yet. We can hypothesize, but there's just no data at this point in time. So I think that groups which are pursuing unselected sequencing for cohorts that's where the future is. So we're trying to do some of that. Stephen Kingsmore and Becky Reimers out at Rady Children's and UCSD are working on that as well. And so I'm excited to see what some of these groups come out with.
Awesome. Dr. Lazar, do you have anything to add, or?
Yeah, I think that, I think that's where we're at right now. I think that really we need to think of HIE as it can be the etiology or cause of certain difficulties, but genetic testing, I just want to say, shouldn't necessarily take away a diagnosis of HIE, and especially kind of the community and things too, because they may be interrelated, but they are not necessarily in the right situation exclusionary. So I think that that's going to be one of the tough parts. And the only way to be able to understand that is if, as costs continue to go down and there's better genetic literacy, that we call it, and understanding from non-genetics and non-specialists. And then also as it becomes more commonplace just for families and things too, I think that this type of testing will become just much more common in general. And that will really allow us to then backtrack, because we're already using it clinically. Let's now dive into what's already been available to understand it a little bit more. So that's where I think a lot of the research will end up coming from.
Wonderful. And I know we're nearing the end of this session. We always love to ask our experts for any recommended resources that you have in mind, like where families could go to learn more or find more information about the relationship between HIE and genetics. So Dr. Lazar, maybe you can begin with yours.
Yeah. So I would say there isn't much out there. I will say
things
that,
we've also heard before.
Yeah. I would say, honestly, I mean, I can't help but promote you guys. But Hope for HIE has a kind of a frequently asked question and kind of a brief page that talks a little bit about genetics and HIE and mentions a little bit of the basics of it, then also gives a lot of really good links to understanding what genetic tests are. So I would say the most information that's out there is once you've already had the genetic testing or have a genetic diagnosis or answer. And a lot of times that's family organization and groups are where people are getting most of their information, especially for these very rare genetic disorders where there may only be 20 in the world. And then, so some of those kind of validated information, but the only good single source is, and I swear this wasn't a plant, is the Hope for HIE website now.
Thanks. Yes, my bribery worked. Thank you. Yes, for saying that. Dr. Parobek, if you would like to conclude with any resources you have in mind, if you have any to share.
Yeah, I think, there's just a handful of studies that I know of that address this. And so we can maybe provide those links in the show notes or to that page next time you update it. And hopefully there will be more coming out. I know of a couple studies in the works, so hopefully there will be more. But I think at this point, like a lot of families with rare diseases are experienced with, families get comfortable reading primary literature because there's really not a lot written for non-medical audience about a certain diagnosis. So I think that may be where we're at in terms of genetics and HIE.
Yeah, but on that note, that's why we're so grateful to have experts like you to take time out of your day and your practice to meet and inform our community members about something that is, evolving and something that is so pertinent to their lives. So thank you again for joining us today. As always, we're going to take this video and we're going to upload it to all of our social channels, our YouTube channel under our medical advisory board playlist, along with a lot of other topics that we've spoken about in the past. And then we have key takeaways that we create on our blog and to disseminate on Instagram and Facebook, so that way this can just be accessible for everyone, and everyone can learn about all the wonderful things that you had to share with us. So thank you again for your time, and we can't wait to speak to you two again and see all of the wonderful things you're doing with research in this area. So thank you.
Perfect. Thank you so much for having us.
Of course.